Welcome back, everybody. We're now going to jump into the second half of this lecture, which is going to cover the secondary assessment. So we reviewed the primary assessment. This is where we identify most of our major life threats. After we finish our primary assessment, we want to take that moment to stop, reflect on what we found, determine a patient priority, and figure out some basics on how quickly and how slowly we might get out of the environment that we're in. After we've kind of made that primary assessment, also assessed the scene, it's time to take a little bit of a deeper look into what's going on with our patient. So this is really going to investigate all of the problems that may be going on and kind of elicit some more information about our patient specifically that might give us a better idea of how to proceed. So it's broken down into a few main components. The first one here is the physical exam. So we're actually going to now put our hands on the patient, on their entire body, to figure out what else might be going on. The chief complaint, especially with a minor isolated injury, is always obvious. Someone's going to tell you that their ankle hurts, you lift up their pant leg, and all of a sudden there's a swollen ankle staring you in the face. But what we want to practice is a really, again, cohesive and consistent assessment where we make sure that there's nothing else going on. So that's where our physical exam really comes into play. We're also going to quickly review vital signs. Vital signs are some measurements that we've already introduced that give us an idea of how that person is doing physiologically. Some of the less obvious things that don't necessarily require our patient to tell us about, but that we can take on our own, what we call diagnostics on a patient. We're also going to investigate that patient's history. This is going to be the history of the present illness, so we're going to investigate their injury. We're also going to take a look further back into their medical history to see if there's any red flags that concern us even more. And finally, once we gather all this additional information, we want to kind of reconsider that priority. In general, there's not going to be anything that we find in our secondary assessment that's going to reduce our suspicion or reduce the level of response necessary. Normally, what it might do is increase our suspicion. It might increase the problems that we're likely dealing with. So the physical exam is really our head-to-toe exam. So this is a good way, again, to check for any other injuries that are outside the realm of what they've expressed in their chief complaint. So what I normally tell patients before I do a physical exam is something like, well, I understand your ankle's hurting, but just to be sure, I'd like to do a quick physical exam on the rest of your body to make sure that there aren't any other injuries going on. Sometimes an ankle injury can be so painful and severe that it's distracting against some other injury, and we want to find out about that now. So in general, we're going to move from head down to toe. We want to put our hands on the patient. We're palpating for any kind of injuries, deformities, moving very consistently from the head to the toe. So quickly, let's just click to the next slide here, and we'll get an appreciation for what sort of things we're looking for. We have a mnemonic that's very comprehensive in describing the different elements that we're looking for in our physical exam. And this stands for deformity, contusion, abrasion, puncture, burns, tenderness, laceration, and swelling. So we have all these different observation points. I believe most of these terms have been covered in other lectures. Please let us know if you're unsure of what any of these terms mean, but they're general indications of some sort of injury. When we do take the time to examine for DCAP BTLS, when we're observing for deformity, contusion, etc., we want to note where the thing is, where they're painful, and the severity of that pain. At this point, we're starting to better develop what we kind of consider our priority of problems. If it's the immediate chief complaint, a lot of the time that's what becomes our main priority, but other times we can elicit information that changes our priority. If a patient first complained of severe arm pain, we move into a patient assessment and now we find that there's back pain associated as well, well, all of a sudden that might take a lot more resources than a simple arm injury, and that might become our priority. So when we do a physical exam, we want to ensure that we use that time as best as we can. And the thing that I like to do is use the body as sort of a tour guide for my questions. If you watch experienced providers perform a physical exam or a patient interview, a lot of the time they'll have so many questions that you wish you had when you were with your patients. The best way for me to have learned these sorts of questions is to really think about the body as, again, your tour guide or your reference guide to some of these questions. When I'm looking at the head, when I'm feeling the head for any kind of deformities, I'm also thinking about what's inside the head. Well, their vision's inside their head, their awareness, their confusion. And so that's going to guide me to ask questions like, are you having any difficulty seeing the world today? Are you having any confusion right now? Have you been able to think complex thoughts recently, or has that been a problem for a long time? So a lot of these sorts of landmarks as we move from the head to the toe will remind us about those sorts of problems to ask for. There are a few specific questions that we want to ensure that we ask about, or assessment points that we want to address when we're doing our physical assessment. One of which is with relation to the eyes. We always want to take a look at the patient's pupils. Obviously, on a real patient who's able to talk to you, you can simply ask them to open their eyes. If you have a little light, we'd like to shine the light into each eye. So when we look at that patient's pupils, we're looking for a specific acronym, and that acronym is PERRL. P-E-R-R-L. Pupils are equal, so both pupils are about the same size when we're not shining a light. They're round. We want nice round pupils, and that they're reactive to light. So we notice that each eye will react to light shown into it individually. When we observe for the neck, when we palpate the neck, we're looking for any kind of neck pain. We're also looking to see if their trachea or their windpipe is midline. We also want to note if there's any extended veins on the neck. That's called JVD, or jugular venous distension. When we get down to the chest, we want to ensure that the patient is not experiencing any chest pain or difficulty breathing. At this point in our patient assessment, it's also a good time to listen to lung sounds. I know I mentioned that previously, and you'll be introduced to lung sounds more in the respiratory emergencies lecture. I move down to the abdomen. It's important to palpate the abdomen, obviously, but again, we can use our guide to asking questions about the abdomen. I can consider that abdominal pain might be a good question, any sort of nausea or vomiting. Also, how their bowel movements and urination have been, if they've been regular or if there's been any kind of discoloration or abnormality associated with them. We want to move down to the pelvis and make sure that the pelvis is stable. We're also going to check all four extremities for what we call perfusion, motion, and sensation. So we want to make sure that there's strong pulses, that we have good skin color. We want to make sure that they have intact sensation as well as movement. And I'll show you again how to assess these just in a moment. When we complete our physical exam, we also want to make sure that we check out the person's back to make sure there's no back pain or any abnormalities on their spine. This is done easily by performing what we call a log roll, which will be introduced later on in this course. So I'll do just a quick physical assessment on this mannequin just to show you exactly how I would conduct a physical exam on a patient. So again, we're going to move head to toe. I'm going to start up the head, and I'm palpating for any kind of tenderness, any kind of broken skull, any kind of bleeding. Want to feel the cheekbones as well. Make sure that the nose is intact and the jaw is stable. It's a good time to look in my patient's pupils with any kind of light that I might have with me to check for pupillary response. Again, we're checking that the pupils are equal and round and reactive to light. I can move down to the patient's neck, and even with the patient laying flat on the ground, I can get a pretty good assessment of their neck by simply putting my hand just in the crook of their neck and moving down just underneath their body. I'm also looking at their neck just to observe for any jugular venous distension or shifted trachea. The trachea should be right in the middle of their neck. I can move down to the patient's shoulder. Many times I will just grasp the shoulder in the front and the back right on where the joint is and press. Shouldn't hurt. I can also press on this side to check this patient's chest wall to ensure that it's intact and non-painful. I'll put my hands just on either side of their rib cage. I'll ask them to take a nice deep breath. As they're taking that deep breath in, I'll just put slight pressure from the outside, direct it inward to see if that elicits any pain. If a person has a specific complaint to their ribs, I might investigate that area individually. Again, while I'm examining their chest, I'll ask them if they're experiencing any chest pain, if they're experiencing any difficulty breathing. I move down into the abdomen, and I want to inspect the abdomen. So the first thing I would do is just expose their abdomen, see if there's any gross discoloration of the skin, any large bruising, or any sort of abnormal masses that are obvious on inspection. After I inspect it, I would like to palpate. So in order to palpate the abdomen, we're going to palpate in the 4 quadrants of the abdomen. Upper left, upper right, lower left. When I palpate, I'm simply using the tips of my fingers and sort of rolling in while I increase pressure on the abdomen. All 4 quadrants. I'm checking for any sort of painful response. I'm looking for any kind of abnormal masses that I feel. The other thing that I can do is check for what we call rebound tenderness of an abdomen. And I'll just do this without telling the patient. I'll just normally inspect their abdomen, and on the last one, I'll push down and I'll let go nice and quickly. When we talk about abdominal injuries and illnesses, you'll understand why we do that later. If I move down to the pelvis, the best way to check that the pelvis is intact is simply to grasp the patient's pelvis on what we call the iliac crests, and we'll show you how to find those on your patient in a practical session. And when I press, I'm really just pushing these 2 bones sort of together. I don't want to rock the patient. I don't want to, put force on one side while lifting on the other. I just apply gentle inward pressure on both iliac crests to see if there's any sort of movement or pain associated. As I move down the lower extremity, I'm really grasping that person's leg on both sides with my hands and checking for any kind of deformities or abnormalities as well as pain. I will do the same thing on the other side as I work down the body. At the time that I get down to the feet, I want to check for what we call a pedal pulse. The easiest way to check for a pedal pulse is to practice checking for a pedal pulse. And a good location is right here on the top of the foot. I encourage you to practice that on yourself as well as other people. I'll move now up to the upper extremities to check the same sorts of assessment points. Simply working my hands down the patient's arm all the way to the hand. By the time I get to the hand, I'm going to check for a pulse. This is checking for the radial pulse. I also want to ask the patient if they have normal sensation in their hand. I can also differentiate among their fingertips by having them look away and asking them to tell me which finger I'm touching. Hopefully they tell me it's their thumb. Again, ask them to tell me which finger I'm touching. Hopefully they tell me it's their pinky. I'll also ask them at this time to grasp both of my hands equally, as hard as they can, to feel for any sort of decrease in strength. I failed to mention it before, but when I'm assessing the legs, I can also have them test the strength of their lower extremities by asking them to pull up towards the top of their head with their feet, and then also to push down towards their toes with their feet, applying slight resistance to ensure that they have intact strength in their lower extremities. At this point, I'm almost done with my physical exam. It's now time to check the back. So I want to log roll my patient. The easiest way to log roll them is to first move their inside arm up. We can also lift the outside leg into a 90-degree position. I'm going to roll this patient towards me. If I have a partner who's able to support their C-spine, or as we'll teach you later on, applying a cervical collar is good before we check the spine, especially if we're worried about any kind of back injury. So once we have the patient rolled, with the help of our partner, I'm going to just work my hand all the way down the patient's spine, feeling for each individual vertebrae, ensuring that there's no pain and ensuring that there's no deformity. Once I'm done with a coordinated effort, we'll log roll that patient back down. I can place them back into an anatomical position. And now we've completed our physical exam. So now we'll just briefly discuss checking for vital signs. We've already covered a couple of these in the airway breathing circulation portion of our primary assessment, but it's important that we check those initially, mostly just to get an appreciation of their presence. And then after we've completed our primary assessment, maybe we've completed our physical exam, we want to start noting these very accurately and consistently. So the important part about vital signs, obviously to know how to do them is essential, but it's very important that you track them over time. So we're really looking for trends in vital signs. It's not super helpful just to have one set of vital signs. We want multiple sets. So here's what we classify as our vital signs. The pulse is obviously just the rate of their pulse, the quality and the location. The respiratory rate is what we've already talked about before. Skin, again, another note to recognize their temperature, their color, and the moisture of their skin. The level of responsiveness we will also include in our vital signs assessment. We want to know what their AVPU scale is, alert, verbal, pain, or unresponsive, as well as their ANO scale. And we want to see, again, these things over time so that we know whether or not they're improving or deteriorating. We also want to check for what we call cap refill. The easiest way to check for cap refill is to take their finger, monitor their nail bed, press down on the nail bed for a couple of seconds, and release, noting that that nail bed should become nice and pink pretty quickly, hopefully within 2 to 3 seconds. Note that if a patient is cold, their cap refill is going to be delayed. It's not necessarily a sign of poor perfusion. Finally, we want to take note of their blood pressure. The actual techniques to take a blood pressure will be covered in your practical sessions, but just understand that a blood pressure is a good way to assess for perfusion. We've already assessed the skin for perfusion. We've also assessed the cap refill to see what the perfusion is like, but the blood pressure can be really helpful in getting a little bit more in-depth into their perfusion, because the pressure that we get when we take a blood pressure is really telling us how well the body is doing at delivering that blood, the oxygen, the nutrients to all of the tissues. In general, we kind of call a 120/80 the average blood pressure. In the modern day, we extend that out quite a bit before we consider it an abnormal blood pressure. It depends mostly on the patient's past medical history, their age, it might even depend on their ethnicity, their gender. So in general, we consider blood pressures to be low if they're outside of kind of our normal limits. When we look at a blood pressure, we're looking at two numbers. We're looking at the top number, which is called our systolic blood pressure, and that's the 120 in the 120/80. The 80 is what we call the diastolic pressure. And that diastolic versus systolic are really referring to the specific function of our heart. If you remember, when we described the function of the heart, you have these 4 different chambers, groups of 2 that are divided into the atria and the ventricles. When our ventricles contract, we consider that to be the systolic pressure that we see in the peripheral vasculature, because that's really the pressure of the ventricles moving the majority of our blood through our heart. The diastolic pressure is really that relaxation pressure, or the pressure that we generate when our atria are contracting to fill the other part of our heart with blood to then move it again to the rest of our body. So that's the differentiation between the systolic and the diastolic blood pressure. The ratio is important. That's what we call a mean arterial pressure, but we're not going to get into that in this course, just to understand that it's important to know both numbers, and both numbers should be within a reasonable ratio. So again, when we have low blood pressures, we're going to call that hypotension. When we have high blood pressures, we call that hypertension. Hypotension we can define as anything less than 100, pushing all the way maybe into 90 systolic for people that either know they have a low blood pressure or are very small, young petite females. As far as hypertension goes, it's hard to delineate exactly what determines high blood pressure, but a good starting point is anything over 140 systolic. Again, it's important to reassess vital signs. We want to reassess all these different forms of vital signs in order to get a good appreciation for how this person's doing over time. For unstable patients, it's important to reassess vital signs every 5 minutes. And for a stable patient, every 15, maybe even 30 minutes is pretty reasonable. Again, this is going to change a little bit based on what environment you're in. If you're in a very technical wilderness environment, it's going to be pretty hard to assess vital signs every 5 minutes. But when you do have the opportunity, that's the goal. So we've already mentioned it a couple of times before, but it's important now to get a really good understanding of how to check a pulse. So we have a couple of different locations where we can check a pulse. The 2 primary ones are the carotid and the radial. So we'll start with the radial. The radial is easy to find. You can probably find it on yourself sitting here in your chair. Basically, you need to identify the thumb side of the forearm. This is where the radius is on your arm. You can find the bony part of the radius over on the lateral aspect of the lower arm, and move your hand slowly inwards or medially until you find a nice little groove. Inside that groove, you should be able to find the radial pulse. If I kind of show you on my hand, I'll start again right out on the bony prominence of my radius. I'll move slightly in until I find a little soft pouch, and in that indentation, I can very easily find my radial pulse. So try that on yourselves, try that on your family members, just to get an appreciation for finding a radial pulse. Moving up to the carotid, thankfully this guy has had his neck skin removed. So we can see, at least on this mannequin, where the carotid should be found anatomically. In general, I like to start by finding the trachea, because the trachea is very obvious to feel. It's a very hard cartilaginous structure, and it's right where your windpipe is. On a male, it's right where the Adam's apple is. As I find that trachea, I'm going to start moving my fingers back towards the posterior neck, essentially, and slightly pressing in. When I get probably around 1 inch to 2 inches away from my initial starting point, I should be able to press nice and deeply and feel a carotid pulse. Again, if I show that to you sort of on myself, I'll find the trachea, find the side of the trachea, and start moving my fingers about 1 inch to 2 inches back until I feel a carotid pulse. As I mentioned before, it's important to try to palpate a pulse on the same side that you're working instead of reaching across the trachea and potentially inhibiting their ability to breathe. So the last thing to note about pulse locations is that they can give us a good understanding of a blood pressure if we don't have a blood pressure cuff. In general, we can relate a pulse that's absent at a radial location as a blood pressure that's less than 80. So at about 80 systolic, we will likely have a radial pulse. As soon as the blood pressure drops below 80 systolic, the blood pressure is likely less than 80. As we move up to the carotid, if we have a carotid pulse, we can assume that the blood pressure is at least about 60 systolic. Once the carotid pulse disappears, we can assume that the blood pressure is less than 60 systolic. So now we've talked about the physical assessment, vital signs, and our last part of this lecture is dealing with the patient history. So as I mentioned before, the history involves both the history of the present illness or injury. I want to get a little bit more in depth into that particular problem, as well as taking a step back and looking at the patient's history as a whole as it relates to their medical history. So the first thing we'll investigate is a mnemonic called SAMPLE. S stands for signs and symptoms. So we want to get a good idea of what sorts of signs and symptoms that patient's having. And when we investigate these questions, we're asking them to the patient. So when we ask the patient for the S, we're asking them, what sort of signs and symptoms of an injury have you had? What sort of symptoms have you been having? The signs are external signs that we can see that are abnormal for that patient. A stands for allergies, and this is specifically relating to allergies to medications. This is very important if we ever administer medications to a patient that we know that they don't have allergies to that medication. We can also ask them if they have any food allergies. That's particularly important if we're ever planning on feeding these patients. M stands for medications. These are medications that patient is currently on. They can be prescription medications. It's also important to note over-the-counter medications. At this point, I also like to ask patients whether or not they've been ingesting any drugs or alcohol, recreational or drugs of abuse. P stands for past medical history. So this is anything that the patient sees a doctor regularly for, any hospitalizations, any surgeries. Do you have any problems with your heart? Do you have any problems with your lungs? Do you have diabetes? Some of those big general categories are nice to ask about at this point in time. L stands for last ins, last outs. So when was the last time you went to the bathroom? When was the last time you ate? And E stands for the events leading up. So what was going on with you before you had this accident? It's an important question to ask because it might give you a clue into why they fell down and twisted their ankle. Oh, well, I started to faint because I was feeling dizzy. I think it's probably my low blood sugar. Something like that might come out when you ask the patient specifically what happened to you right before this happened. The HPI, or history of present illness, is more in-depth investigation into the problem that they're presenting to you with. The mnemonic we have here is OPQRSTU. O for onset. When did this thing start? When did your injury start? When did your abdominal pain start? P stands for provokes or palliates. What makes it better? What makes it worse? R stands for radiating. Does the pain move anywhere, or is it specific to one location? S stands for severity, and that's on a scale of 1 to 10. 1 being a simple pinprick to your finger, 10 being a bear is eating your arm. And T stands for time. It's just another way to look at the onset. You get an idea of how much time has passed between the onset and at the point at which you're assessing this patient. Finally, U is a great question to ask, and this is, has this ever happened to you before, or what do you think is going on? Patients that have an extensive medical history and experience with this sort of illness or injury before will definitely be able to clue you in on the severity. In review, here's just a little schematic of where all of this fits in, what it looks like when it's all put together. I encourage you to watch the demonstration video entitled Assessment. That will give you kind of a bird's eye view into what an assessment looks like out there in the wilderness. But just remember that these assessments need to be comprehensive, they need to be consistent, they need to be orderly. It's important to move from your scene survey into your primary assessment. As you move through your primary assessment, don't forget to stop and correct the problems that you encounter. At the point that we've gotten through our primary assessment, stop, take a moment, assess your transport priority, and then move into your secondary assessment. That's going to include your head to toe, your vitals, your sample, your OPQRST, and your documentation. So please, if you guys have any questions, direct them towards the forum for this lecture series. You can also always email your instructors. Again, these are great things to practice at home if you have the chance. You don't need to necessarily make the most complicated assessments. Again, this basic structure of question asking, physical assessment, will all play into a specific order for every patient encounter that you have. It really doesn't matter what they're complaining of. You should strive to include all these assessment points in any patient encounter. I hope you all enjoyed this lecture series. Please let us know if you have any questions.